Hello, my name is Shellen Lee, and welcome back to another learning module on orthopedic procedures. Today, we will specifically be looking into how to properly take hand radiographs. Although hand radiographs are known to be one of the most simplest radiographic procedures, it is surprisingly also included as one of the top 5 radiographic procedures where the staff at UNC facilities are most often making errors either from positioning, patient safety, or image quality malfunctions. This learning module will explain how to thoroughly and successfully complete a hand radiographic exam in order to avoid these types of errors. So the standard protocol calls for a posterior-anterior image, which is PA, a posterior-anterior oblique image, one lateral image, which is taken lateral medially. All of these images are done tabletop with a 40-inch SID. You can use one 10 by 12 inch IR to have two projections on one, and you can include the third projection on another 10 by 12 inch IR. The size of the IR really depends on the size of the patient's hand. If you're working with a pediatric patient, then an 8 by 10 inch IR would be appropriate. Alright, so for the PA hand projection, positioning is very simple. You're going to have the patient just sit by the edge of the radiographic table and place their hand on top of the IR. You want to make sure that the patient's hand is faced palm down with their fingers spread apart and hand flattened onto the IR. You want to open up the collimation to include all of the fingertips down to the distal part of the wrist, and make sure that you mark which hand is being imaged. For example, if it's the left or right hand. The central ray is going to be perpendicular and it's going to enter the third metacarpal phalangeal joint. So it's fairly hard to make a repeat on a PA hand because they're pretty simple exams. You just want to make sure that there's no rotation. You want to see the concave sides of the bones, that they're symmetric, and you see equal soft tissue. You also want to make sure that there's no deviation in the hand, wrist, or forearm, and that they're all straight in the same plane. You want to see open metacarpal phalangeal and interphalangeal joints, and make sure that there's no overlap of fingers. So you're going to have the patient spread out their fingers beforehand onto the IR. You want to include the distal radius and ulna all the way to the fingertips. And you generally want at least 1 inch past the joint space. Include the soft tissue. Do not cut the soft tissue because there could be some pathology on the soft tissue as well. So the positioning for the PA oblique projection is very similar to a regular PA projection, except you're going to have the patient laterally rotate their hand about 45 degrees. The central ray is still going to be perpendicular to the IR and enter the third metacarpal phalangeal joint. And again, you're going to have the patient seated by the edge of the table with the forearm and hand on the same plane. And from these two pictures, you can see that the picture on the left shows the patient holding their position as their hand is slightly rotated out about 45 degrees. The picture on the right shows the patient's hand on top of a sponge, and that sponge is basically also giving you the oblique projection. This sponge is used for patients who can't freely move their hand or can't hold the oblique position for a long period of time. It's also pretty hard to end up making a repeat of a PA oblique hand because it is a pretty simple exam. You just want to make sure and see if the desirable positioning characteristics are shown, such as there's overlap or superimposition of the third, fourth, and fifth metacarpal bases, and there's kind of slight superimposition of the third, fourth, and fifth metacarpal heads. The second and third metacarpals should be separated. Also, you want to make sure that the metacarpal phalangeal joints are all open and the interphalangeal joints are open if the fingers were parallel to the IR. There should be no superimpositions of the fingers. Basically, if you included all of the fingertips down to the distal wrist, and you see the fingers from the side profile and all the metacarpal phalangeal joints are open, then there should not be a reason for you to repeat the PA oblique hand. For the lateral projection, it can be done as true lateral shown in the picture on the left or fan lateral shown in the picture on the right. For the true lateral, the patient is going to be seated at the end of the table. The wrist and hand are in lateral position. Basically, it looks like a karate chop. The medial aspect of the hand is touching the IR, and the fingers are extended and superimposing each other, but not the thumb. The thumb is going to be sticking out. The central ray is going to be perpendicular to the IR, and it's going to enter the metacarpal phalangeal joints. And basically, the true lateral is done to localize foreign bodies, look for dislocation of fingers, whether there's anterior or posterior displacement of a fracture, or if the patient can't do the fan lateral. The fan lateral is done exactly the same as true lateral fingers instead of superimposing them. Usually, the patient does not need a special sponge like shown in the picture, but you bring out the sponge if the patient can't hold this position for a while or if the patient can't hold still. So the metacarpals are going to be superimposed, but the phalanges are separated in the fan lateral. Some radiology departments do this routinely, such as all of UNC. Actually, all of UNC facilities use the fan lateral protocol, and they rarely use the true lateral. So you basically just have to check with the department protocol. Reasons for repeat of the lateral hand could be possible if you were to clip off part of the finger or some anatomy, or clip off the distal wrist. You just want to look for the characteristics that I've mentioned in the previous slide. For example, on the true lateral radiograph, you want to make sure all the metacarpals are superimposed on top of one another except for the thumb. And for fan lateral, you want to make sure that the metacarpals are superimposed except for the phalanges. They should be separated. You also want to look for open joint spaces and include soft tissue as well. I put a star on the AP oblique projection because this projection is only used to see if the patient has arthritis or to check up on a patient who has arthritis. Both hands are imaged on one IR, and usually you begin with the hands supinated and then you're going to immediately rotate the hands inwards about 45 degrees. The central ray is going to be perpendicular to the IR, and it's going to enter between the two hands right around the level of the metacarpal phalangeal joints. All bones of both hands should be included, and there should be no superimposition of the metacarpal heads. This is not part of the routine hand positions, and yes, again, I mentioned it's done to detect rheumatoid arthritis. And of course, you want to mark both sides on the IR, marking which side is the left hand and which side is the right hand. You also want to rotate the wrist enough so that the pisiform is sticking out and you see an open joint space between the pisiform and the rest of the carpals. The bone age radiograph is another type of procedure that is done to determine the skeletal maturity of a pediatric patient who may have growth or endocrine disorders. This is particularly useful for children who are on growth hormone therapy or in delayed or advanced stages of puberty. The exam consists of a left-hand radiograph that includes all the way down to the distal wrist. The appearance of carpal bones, metacarpals, phalanges, radius, and ulna on the radiograph are compared to radiographs from the Standard Atlas of Bone Development, which may be based on data from a large number of other kids of the same gender and age. Two popular atlases would be the Graylich and Pyle Atlas and the Tanner Whitehouse Atlas. There can also be trauma patients in which we cannot always have the patient positioned for the perfect PA, oblique, and lateral radiographs. For example, in the image shown below, you see that the patient is not able to flatten out her hand fully and spread out her fingers for the PA radiograph on the left. On the right-hand image, I think the patient was trying to attempt a fan lateral position, but the wrist looks more like an oblique position. Depending on the clinical site you work at, there will be protocols on whether or not the patient will stay in the cast for the radiographic procedure. If the patient does end up staying in the cast, then you'll just have to work with what you have and just get the best possible image that you can. So here are some other reasons that you would repeat a hand radiograph. Like I mentioned in the previous slide, there's trauma patients. When you have patients come in with casts and splints, and you want to be able to position the patient to get an ideal image, but keep them safe and not force them in any position that will be harmful to them. You want to look out for movement or blurriness. This especially applies to people with Parkinson's disease or older patients who are not able to hold still for a long period of time. You can use sponges or immobilization devices to keep their hand from moving. Also, you want to be on the lookout for artifacts, which includes bracelets, rings, or any type of metal that can obscure the pertinent anatomy that we're trying to look at. And you want to make sure you mark the right side of the body or the correct side of the body. So if you are imaging the right hand, make sure your right marker is on the IR. You also want to get an adequate density, especially for hyperparathyroidism patients. You want to be able to see the bony trabecular patterns for these patients. You want to obtain a good contrast as well, so make sure you have a good level of KVP. Thank you so much for tuning in to this learning module on hand radiography.